Now, I'm
Yeah.
going to talk on a totally different aspect. First of all, I belong to the BC era. When I say BC, I don't mean before Corona, but I mean before computers. I was the last neurosurgeon in India who was trained when there was no CT scan, when there were hardly any computers in hospital care. So far as telehealth is concerned, I believe that healthcare ethics is related to medical and healthcare decisions taken during the delivery of technology enabled remote healthcare. I think these four words very clearly decide what exactly is telemedicine, technology enabled remote healthcare. Now, we need to think of the future. I could not have dreamt even 5 years ago that there would be a full 90-minute session dealing exclusively with ethical issues in telehealth. And I wish to congratulate the organizers. I have given so many talks in the last 21 years, but this is the first time there is a full session on this. And I think this shows that the time has come. Let's spend a minute looking at how the world will be in just a few years from now. This is a slide from the World Economic Forum, an interview of 800 leading technology executives all over the world. 10% of people wearing clothes will be connected to the internet. 90% of the population with regular access to the internet. And believe me, all these predictions was before the COVID pandemic came. So the presence of the COVID pandemic has only accelerated all this. And I am certain that in my lifetime, I will see that digital healthcare has probably taken over brick and mortar hospitals. I was astonished to see that there were 1,635 PubMed index papers when you do a search only with the word ethics and telemedicine. And if you look at the graph on the left-hand side, you will see that 90% of these papers have come in the last 24 months. I was, of course, very pleasantly surprised to see Vinita Agrawal and Kishore and Saroj Mishra's papers also mentioned in this. So this clearly shows that ethics and telemedicine has now been recognized as a distinct, shall we say, special discipline within the broad area of telehealth. It was amazing to see the number of programs, webinars, of course, most of it outside India, particularly in the United States, the number of editorials, the number of review articles written on ethics and telemedicine and telehealth. This was indeed a tremendous experience for me. One of the slides which I showed here, pictures I showed here, have been emphasizing what I have been repeatedly stating over the last 2 decades. I am convinced that technology is a means to achieve an end. Technology should not be considered the end in itself. As a neurosurgeon, I always remember what Lars Lexell, the inventor of the Gamma knife, which at that time was the most sophisticated technology in healthcare, he said, I quote, "A fool with a tool is still a fool." I think it is a human challenge of telemedicine. It is a man behind the machine that decides when telemedicine or telehealth is to take off. I am convinced that in spite of 4G, 5G, 6G, and 7G, if telemedicine is really to be incorporated into the core of the healthcare delivery system, our brand ambassador should be the beneficiary. How many times has the beneficiary, a patient, gone away saying, wow, that was amazing. I could see no difference at all between the person holding my pulse, looking at me, palpating my abdomen, and what I saw on this giant screen. What an effect it was. This is something which unfortunately is not stressed upon. We are experts in technology. We talk about legalities. We talk about regulations. We talk about everything excepting the human touch. I believe that ethics, I like the word professional ethics, which the previous speaker used. Let us be very honest. All of us know whether what we are doing is ethical or not ethical. You do not need definitions. A bench of the Supreme Court said 2-3 decades ago, they said, obscenity lies in the eyes of the beholder. This is what the Supreme Court judgment said. And I similarly think that we, in our heart of hearts, in our conscience, I know whether what I did was ethical or not. Coming back to ethics and telemedicine, we have already dealt with confidentiality, privacy, security. Quality of care should not be less than that of a face-to-face consultation. And of course, we need to protect ourselves from malpractice. I understand the first case was already filed a couple of months ago with a movie star where telehealth, not confining to what was passed in the regulations, is actually the first malpractice using telemedicine has already become a reality in India. Informed consent, I'm not going to deal with this. I'm going to spend the next few minutes on talking of doctor-patient relationship virtually. First of all, I am convinced, as most of us are, that in the future, brick and mortar hospitals are going to become less and less. We need to double our doctors, triple our nurses, quadruple our paramedics. And no less a person than the chairperson of the Apollo Group, 70 hospitals, 10,000 beds, etc., has publicly mentioned that the Apollo Group as such is not going to have further new hospitals, merger and acquisitions, build 500-bedded hospitals, etc. Instead, they are going to develop 100, 200, 300, 500 satellite units over tier 2, tier 3 cities, which will be linked to the main hospitals. And this is going to be the future, whether you like it or not. As I mentioned in the very beginning, though a technology buff, I still belong to the good old-fashioned doctor. I believe that clinical telemedicine is important. I believe that clinical wisdom should be contextual. And I'm very happy that in the regulatory guidelines of the TMC, it has again and again been repeated that everything is contextual. What is to be done in a telehealth consultation at that time, at that place, for that patient, by you, from where you are, taking socio-economic picture and specific requirements for patient and the family at that time. I always try to find out why the patient wanted a teleconsultation. Was he compelled to do it because he had no choice because of the lockdown, or did he do it for convenience, or because he thought that teleconsultation is as good as a face-to-face consultation? Never ever get overawed by rules and regulations. Do what you think is the best for the patient, so long as you are conscience clear. At the best, you can be accused of an irregularity, of not complying with rules and regulations, but you will always be excused. Clinical judgment is absolutely mandatory. I strongly believe that the greater the technology, the greater is tender, loving care which is required. As a clinician, act in good faith. Always have only the patient's interest first and foremost. In the earlier years, when technology was not as good as it is now, on several occasions, I have very convincingly told the patient, I'm sorry, I'm not satisfied with the quality of the CT images which you have sent to me. I need to physically examine you. I need to look at your fundus. I cannot look at your fundus now. I cannot proceed with the teleconsultation. Please come here. On several occasions, I have mentioned your history is very strongly suggestive of a convulsion, of a seizure disorder. But once I brand you as an epileptic, it's very unlikely anybody will reverse the decision. And therefore, I think we need to see you here. We need to see you getting an actual fit, or you take a video, send an actual fit to me. In other words, clinical, clinical, clinical. I am an old-fashioned physician. I would still like to do a rectal examination to find out the size of the enlarged prostate. Whereas my student may be much more comfortable with a 4D pelvic ultrasound, and he may not think of putting a hand on the abdomen is necessary at all, or a rectal or a vaginal examination. Absolutely right. He is right, and so am I. So you and you alone can decide that. So what is my take-home message? That it is contextual. Everything should be contextual. I believe that ethical practice of telemedicine lies in establishing a sympathizing, empathizing with the person at the other end. Don't look at your watch. Unfortunately, in the real world, seldom of us are professionally attired when we even do a teleconsultation. All these small things matter. The light in your room, the way you look at the patient, everything is important. Internet is a powerful tool today. But again, remember, you need to convince the beneficiary at the other end that for the next 7 to 8 minutes, you and you alone, he and he alone is what you exist for. This ability to transmit your body language is, I think, one of the most important things in making telemedicine succeed. When doctors don't listen, I'm sure many of you are aware that the 6th commonest cause of death in the United States of America from 2015 to 2019 is iatrogenic disorders. More than 300,000 deaths occur every year, which have been proved scientifically is due to iatrogenic deaths. Many of the time it is because we don't get a very detailed history. There is so much of literature published on this. Look at these books, Misdiagnosed, One Woman's Tour of an Escape from Healthcare Land. The patient today is empowered. I strongly believe that what Sir William Osler said 150 years ago is as relevant today in the era of 5G. Listen, listen, listen. He's telling you the diagnosis. Teleconsultation or not, please listen to the patient. Don't only look at the contrast MRI. Don't look at the PET CT. Don't look at the angiogram. Listen to the patient. The patient is a universe of one. Build a rapport, build a confidence, build a trust. I can assure you that you will never have a malpractice suit filed against you, even if you did something wrong, if you have established a trust with the patient. In the 20th century, when I was trained, patients believed that the doctor knows best. In 2021, the patient is as much involved in the decision-making as I am. The missing ingredient in the development of new therapies is the voice of the patient. How often have we taken what the patient wants? Why should I alone decide whether the patient is going to benefit with stereotactic radiosurgery or a radical open surgery? I need to understand what the family wants. This is what is missing now. The e-patient movement will soon come to India. Even today, we have hundreds of societies in India, the Multiple Sclerosis Society of India, and so on and so forth, where patients have got together and they have shared their own notes with them. The e-patient stands not for electronic, but it stands for equipped, enabled, empowered, engaged. Today's digitally empowered patient knows almost as much of medicine as you think you know. ePatients.net is just a question of time before all this comes to India. Techno-cultural medical revolution of the millennium, request to discuss online materials is not questioning your competence. All of us have a king-size ego. Why do I treat it as an affront when the patient asks me, what about the article in British Medical Journal, New England Journal of Medicine, that editorial said that stenting is preferable to open heart surgery? Why does it arouse me? Am I the doctor or you the doctor? This was how the approach was even 10 years ago. This needs to be changed completely. I believe this is ethical issues in telemedicine. I believe that this is what ethics deal with in telemedicine. The ideal doctor is one who's prepared to lose the battle in order to win the war. Have 2025 standards, not 2015 standards. Remember that the future is always ahead of schedule. Do not try to be a perfectionist. Look at every failure as a learning experience. Today, unfortunately, the neurosurgery itself has at least 12 subspecialties: skull-based surgeon, cerebrovascular surgeon, radiosurgery, interventional neuroradiology, etc., etc. We are becoming master craftsmen, superb technicians, skilled in knowing more and more about less and less. This is not the way it should be. Yes, new skills must be acquired, but what got you here does not keep you there. You must be ready for the future. If you do not continually change, you will be history. I like this Venn diagram which composes people, technology, and process. You can see that technology cannot be dissociated with people and progress. Healthcare is something very personal. I've always stressed that it is not akin to buying a pizza online. I can book a movie ticket online. Yes, I can book an air ticket or a train ticket online. I can do a bank transaction online. But believe me, it is very, very different from doing an online, I hate the word transaction, online transaction with a healthcare provider. Healthcare is something extremely personal. You need to make an eye contact with the beneficiary. You need to introduce yourself. You need to see what they are doing, what you are doing. The good news is that excellence in healthcare is neither hard nor expensive. But the bad news is that despite that, in some places, these simple things are not common. Again, what William Mayo said a long time ago, he said, it doesn't matter if care is cutting edge and technologically advanced, if it does not take into account what the patient wants. Patients don't care a damn how much you know. They only want to know how much you care for them. The aim of medicine is ultimately to prevent disease and have a good quality of life, not just prolong life. The ideal of medicine is to eliminate the need of a physician. About 15 years ago, Professor Kamilini Ramdas, a very well-known professor at the London School of Business, met me and asked me if I would cooperate with her and we could do shared medical appointments. I was very much interested. Unfortunately, I think Madras City or the institutions where I work were just not advanced enough to even take that. Today, she herself has published several papers, and I think this is going to be a major way in which healthcare is going to be delivered, particularly in the post-pandemic era. Bedside manner is going to be replaced with website manner. I am sure that the next generation of doctors, there are hundreds of papers already published on website manner. And even a person like me who has been embracing telemedicine, evangelizing telemedicine, I learned so much by reading these papers on website manner. So I think this is the future, shared medical appointments. American Psychological Association have already started this group therapy using telehealth. I think it makes a lot of sense. Now, I deliberately mentioned this because ethically speaking, when I was a medical student, a postgraduate and a teacher, we were always taught about confidentiality. That was a bottom rim. We were always taught that a doctor-patient relationship is sacrosanct. But today, a number of patients will be seen by the doctor in a single group. So I think this is the future, and telemedicine also, group telecounseling is going to happen. So ladies and gentlemen, the ideal clinician should not just be a tech-savvy expert. He should have the surgical wisdom of Sushruta, the compassion of Mother Teresa, the pragmatism of Lord Krishna and the Bhagavad Gita, the genius of Albert Einstein, the innovativeness of staff. In other words, he must be a superman. This was my final slide. So I think our universe has changed. India should no longer follow high standards. We should set them. We no longer should be striving to achieve world class. The world should strive to achieve India class. Nothing can stop an idea whose time has come. Creating awareness and convincing society that geography has become history should be followed. And I'm very happy and once again thank the organizers to bring a very important subject, namely deployment of ethics and trust, and add it to laws, rules, regulations, and compliance. Thank you.